Thank you, Hassan. Now the lectures are open for questions. So we can start from some questions we have online, and one is for you, Shahid. How do you think you can avoid to, you can actually improve the representation of the real population in clinical trials? So when you design your trial, how did you consider your inclusion criteria? Did you try to be quite relaxed so that you could include as many as possible, or you went for stringent criteria?
So, the in terms of the inclusion criteria, so if you're going to get a trial funded, it's got to be pretty airtight, and it's got to be deliverable, and you've got to be able to prove or disprove your hypothesis. Otherwise, no one's going to give you money to it, because otherwise that money could be spent on someone else's trial. So, so we need a population that are at risk of cancer, so that's PSC. The reason we said they have to have IBD as well is because if you're going to prove that if the aspirin reduces the cancer risk, you need a certain number of events, cancer events to happen. If no one gets cancer, or very few people get cancer, you're not going to be able to statistically prove that there's been a reduction. So when we did that, and that's why you have statisticians involved in the trial, and our statisticians crunched the numbers. They looked at the event rates, the predicted event rates, and if we did not exclude, if we did not include patients with IBD, then there would be hardly any colon cancers, and so if you're not getting enough cancers, you can't prove the cancers are being reduced. So that's why we had to have IBD as well. Having to have 12 months post-diagnosis is because clinical practice, if you're a hepatologist, you often see that patients are diagnosed with PSC and within a few months with a cancer, and actually they've had relatively no symptoms before, and it's the symptoms from the cancer has led them to present. But that said, the patients included in the trial would be are real patients, right? You know, they're not aliens out. You know, they're not avatars, right? So they're real people who have PSC, who have IBD. They'll, you know, in local hospitals around the country. And if we can recruit and the results are positive, then that group of patients will benefit.
Thank you very much. I have a question for Mr. Gomez. I mean, one of the big discussions in oncology at the moment is, do we need to move chemotherapy before surgery, or do we need to focus more on the post-surgical treatment and strengthen the treatment with radiotherapy? So do you have any data about your R1 population? I mean, we have some other retrospective data suggesting that N1 is probably a more important prognostic factor. But in your cohort, you've seen that, yes, N1 is associated with overall survival, but R1 is more associated with relapse-free survival. And I think it came out to the discussion at the MDT before that we wanted to monitor early relapse to see if we can, you know, increase the potential local treatment and more surgery or more radiotherapy. So do you have any data about your R1 population? Are they associated with N positive, or did they go through treatment which was not a systemic therapy?
So the data that's currently analyzed is only the hilar cholangio. Yeah. And the R1 that I described earlier is circumferential and or longitudinal. So as long as one of it became R1, then we put it in the analysis as an R1. But I can't tell you offhand without analyzing the data to see whether there's an association with the R1 and lymph node metastasis. What is very clear from our data is if you have an R1 margin, irrespective whether it's circumferential or longitudinal, that your disease is going to come back earlier. So in some ways, that is an indicator that these are the patients who really need adjuvant chemotherapy. But one of the problems we are having, as you can see from our data, that only 180 patients underwent chemotherapy. So I don't know what are the reasons why more patients were not referred to. I do understand that during the period of 2014 to 2018, prior to bill cap, some centers may not have referred for chemo. But what is very clear is not everybody is getting chemotherapy from our database. So to prevent earlier recurrence, we do need these patients to undergo chemo, but I don't know whether this extensive surgery we do on them makes them frail and unable to then have chemotherapy.
Just to mention, it's going to work, but R1 is, so there was a plan, wasn't there, of Arctica RT, which was the adjuvant radiotherapy study that Maria was planning to develop. It wasn't ultimately funded, but the idea was that if you had patients with bad histology, perhaps a kind of adjuvant radiotherapy option could be investigated. But I don't know if that's being looked at in Europe, but certainly wasn't funded in the UK.
And I think there is another question for you, Hassan. I think that you have strengthened the importance of specialization and expertise. So how can we train better the next generation of surgeons, or how can we attract them for increasing the specialism?
I mean, so the reality is, if you want to do HPB surgery in this country, you've got to finish your training. You may or may not be lucky enough to be in a high volume centre that has an interest in this disease. But often once you've finished your training, you go off and do a fellowship somewhere. And that could well be in a transplant centre like Brian has, whether in the UK or abroad. And it may be as part of that, you get exposed to this type of surgery. I think there's a role of mentorship is crucial. Often consultants are appointed, being able to deliver the basics of care, which is around on-call and simple resections, whatever. But if you've got experienced people in a centre, they have to mentor and develop that next generation. So it's a kind of combination of people going away and developing the training for themselves, but also having someone back at base who's helping with the key decision making. And as we've had before, having two people in theatre certainly kind of makes a difference. Even just giving a bit of an opinion makes a big difference.
Thank you. Mr. Davidson.
I've got a question for Shahid. I didn't want to interfere with the surgical expertise. Shahid, first of all, fantastic to get funding for your trial. I didn't have anything to do with reviewing it, but if I had reviewed it, there's a couple of things that I would have been interested in. First of all, you had about 1 in 7 of your patients were already taking aspirin. That's actually quite a large percentage of your cohort that you're planning to investigate. As you know, there was a recent trial of fish oil additives to prevent recurrence in colorectal metastasis, and we were absolutely amazed that a large percentage of the UK population are actually taking fish oils, although it would never be charted in their hospital records. And I'm just wondering whether or not we're estimating the number of people that might take aspirin. We've mentioned that PSC population is quite well informed, and I think if I had PSC and I could see that there was a risk reduction of 30% of getting cancer, I'd be very tempted to take aspirin. So I'm just interested in how you achieved equipoise here. What risks did you suggest this population had from taking aspirin? Because it must be significant to compensate for the possible benefits of just taking it anyway. Often with trialists on a panel, they would say, well, why don't you just give everybody aspirin? Why bother doing the trial at £5 million?
So thanks, Brian. So I'm glad you didn't review the grant. First thing to say. Second thing I would say is that this is the first question that comes up. And I would say 6 out of 7 aren't taking aspirin. So the glass is 6/7 full and only 1/7 empty, right? So that's the first thing I would say. That's the second thing I would say. The third thing I would say is aspirin in the context of PSC and IBD is not without risk. In theory, it can cause flares of IBD. Patients with PSC often have gastritis, GAVE, portal hypertensive gastropathy, varices, so there's a bleed risk there. And the final thing I would say is that this is not the first trial of aspirin in patients. It would be the first in PSC, but there have been several trials, Lynch syndrome, trials in other conditions. There's Ruth Langley, oncologist at UCL, is doing a big international study called Add Aspirin, an international study where people with a variety of cancers are given aspirin as adjuvant treatment. And no prior trial, or this ongoing trial by Ruth, has reported a problem of patients taking aspirin once it's been explained to them why they shouldn't, because A, there's a potential risk if you're taking it on your own. B, we'll never know the answer to the question. And most patients will understand that and comply. And also, Ruth said in one of her studies, they randomly looked at urinary breakdown products of aspirin and found there was no difference in the two, post hoc analysis, and found there was no significant evidence of people who were on placebo taking aspirin. So they're my reasons.
Yes, we have a question from the online platform, and it's for the surgeons here in the panel. So you have both described a 10% mortality for these complex surgeries. Are there any data that can help you predicting which patients have a higher risk of mortality and fall within the 10%?
Yeah. So maybe go on first. That's okay, Danny. Oh, sorry, you want to go first?
Yeah.
You go first. Good.
I'll just tell you from the CAPBIL data, the ones that had higher morbidity and mortality are the ones who had any vascular resection. So if they had venous resection or arterial resection, that led to higher morbidity and mortality. So maybe that is already a preoperative indicator that those patients actually are probably inoperable, even if you can reconstruct the vessels. In terms of prognostic factors, we didn't see anything that made it significant that they were highly likely to get morbidity, because the operation itself is so extensive. You can see our mean population group, it was 65. So most patients in our patient cohort were around the 60 age group. And most of these patients are relatively fit for their age, and hence they can undergo extensive operations.
Yeah, just to add to that, just going back to the international series, which is over 2,000 patients in it. So that data was looked at, and they use a kind of AI algorithm to identify factors that predicted for that futility, which is often early recurrence, death, etc., as a kind of composite. And a number of factors were found, which included, right-sided resections, vascular resections, preoperative cholangitis, etc. All the things that we know as surgeons that predict for higher risk. I think the thing that Danny perhaps didn't mention in your study was the reduction in mortality over time from the surgery. I don't know if you want to say anything
so
about that.
what we did find, which I did not present there, in the two cohort group, what we saw was our mortality did decrease in the second group, the 2019 to 22. And we found at that group, it was only 4%. So the previous group, the 2014 to 2018, that was 14%. So there is a clear reduction in overall mortality from the surgery. And I think most centers have got better through experience in dealing with complex patients like this. and looking them better after post-op, and also identifying which patients are fit enough, like using CPET testing.
And one more question from Simon.
Sorry, it's just a question to both surgeons, really. I mean, you obviously highlight about the importance of occult nodal metastasis that weren't suspected at the time of surgery. How do you think we can get better at detecting that group to potentially avoid unnecessary surgery? Do you think we should be doing aggressive EUS sampling? Is there nodal changes on the MRI or AI technologies? We can look back at those scans and see, could we have predicted that? I just wonder what your thoughts are, because that seems to sort of a major question that needs answering, really.
So I think as a surgeon being biased, that we would assume just because they have lymph nodes there, it doesn't mean it's inoperable. Because as part of the surgery process, we will remove all the lymph nodes and the bile duct in the Porter triad. So the assumption is it's still curative because we are removing what we can see. But clearly having lymph nodes there is an indicator of poor overall survival. Now, the worrying data there presented was the PET scan, because we have recommended PET scan in the guidelines, both in ESMO and the recent published BSG guidelines suggest we should do PET. And actually the pickup rate in PET for the patients who did have PET was poor. So clearly PET is not the answer, but whether you should consider doing EUS sampling of lymph nodes to see whether they have disease there is a question that will answer whether they are N1 or N not. But the problem with that is it will delay the patient journey. So the time to surgery will be delayed because it's getting EUS capacity, getting them the procedure, then analyzing the lymph node. And so that all takes time. And then you are prolonging their pathway. And I think that's one of the reasons why PET is not used in most centers, just because it is going to prolong the pathway. That may be one of the reasons also. Now we trust MRI and CTs more, and staging laparoscopy has had a big drop. We are significantly doing less and less. So
I think the only counter-argument to that is that the thing with this study wasn't designed to look at the futility or whatever of PET scanning, because all the centres where there wasn't PET scanning, we don't know what we would have done, you know. And also we've only got the surgical patients. We don't know the number of patients in whom PET had avoided a futile operation. So the half the patients who had node-positive disease, a lot of those patients would have probably been treated in a certain centre where they never had a PET scan, so we don't know. So you can't really join the two together. I think the main thing from our point of view is that if you find non-regional metastatic disease, and obviously that is advanced disease and you want to avoid futile surgery. But if you have a regional metastatic disease that you would resect, and a bit like the earlier discussion around the 3D modelling, where perhaps there's a kind of vascular invasion or whatever, which would mean the prognosis may be worse, is there a role for initial systemic therapy to reassess the disease biology? So one could envisage a way of managing this is to fully stage by combination of advanced imaging, including PET, to then risk adjust and then perhaps stratify to standard of care, which would still be surgery, assuming it's operable, versus systemic therapy, you know, and that would be quite an interesting strategy clinically.
Thank you.
Okay, we have time just for one last question and a quick answer. Shahid, the question is for you. Do you plan any interim analysis? And if there is a frank benefit, any plan for crossover?
Yes, the answer is yes. Of course, we'll be doing interim analysis. If there is great benefit from aspirin, even better than we hoped, then yes, of course, we would consider that. Based on the historical data, the anticipated effect, the time to recruit, the event rates, all those factors suggest that that probably won't happen at 2 years or 3 years, but we'll be analysing the data and we will be doing an interim analysis, yeah. Okay. Okay. So great. So that's the end of that session. Thank you, Danny and Hassan.